Thanks, Abadiya. Thank you very much. All right. So, apologies once again for starting late. As has become customary for us for every occasion, we would like to get a volunteer to pray for us to begin the program. Anyone touched by the Spirit, as we say.
Let's pray. Heavenly Father, we want to thank you for the gift of life. We want to thank you for the protection that you have given us and even made it possible for all of us to be here. We pray that may today's program be a success to the glory of your name and help us to implement whatever that needs to be implemented. In Jesus' name we pray thanksgiving. Amen.
Thank you very much. So, we are here for a reason, and the reason is to discuss the learning that we have had from the Maternal Mental Health Program, which UK-Aid, the Headley Trust, and Jesse Overseas Agency has sponsored. And for such an occasion, it is customary for us to be welcomed in a fitting manner. And so I would like to invite Peter Badimakiaro. Peter is the Executive Director of Basic Needs Ghana to come and welcome all of us to this occasion. Peter.
Thank you very much, Fred. Before I continue, just a small observation. For the purpose of the slides, I've seen the chandelier seem to block part of this thing, so maybe technical people will look at the projector. Well, I have the singular privilege and honor to welcome you all as leader of Basic Needs Ghana, the representative of the Minister of Health, the Director for Family Health, representing the Director General of the Ghana Health Service, representatives of the Mental Health Authority, I guess Dr. Atta, representative of the WHO in Ghana, Dr. Jima, representatives of the Ghana Somobi Jumadie program. I didn't quite get the name, but forgive me, we had an interaction. UK Aid FCDO in absentia, our dear partners. I'm not giving any order of acknowledgement, but let me say heads of agencies, ministries, and departments of government of Ghana who are here. We do apologies if I'm not able to mention you in person. Then the representative of the Dean of the School of Public Health, University of Ghana, heads of our partners, that is Gupkatmale Society, Center for People's Empowerment and Rights Initiatives, and our colleagues from Basic Needs. The media people who are here present, we welcome you all. I also like to acknowledge the presence of the CBM West Africa advisor, Mr. Emeka, who has traveled all the way from Nigeria to be here with us for this program. Thank you so much, Emeka, for coming. Basic Needs, more or less, has become a household name in Ghana because our journey has been a long one. In the sense that in 2002, Basic Needs Ghana started operations in the country, that is Ghana, with our first program. And we have since moved on and on to do the little bit that we can. It is part of those, our efforts, that resulted in the Maternal Mental Health Project, which, if we were government, would say is one of our flagship programs. With due apologies. One of our flagship programs, in the sense that it was one of the first projects specifically targeted at a specific population group, women and girls who are pregnant or newly delivered mothers and their infants. I'm sure our colleagues from CBM would say a bit more about that. But it was one such project that we were so thrilled about because it was not just innovative but contributing to a niche area, maternal and child health, from the perspective of the mental health of mother and child. Our programs in Ghana have included issues of awareness raising, working on livelihoods of people with mental health conditions and their primary caregivers, contributing to advocacy and policy influencing. And I'm proud to say one of our key successes have been our active involvement in the promulgation of the Mental Health Act in Ghana, and continue to work on the issue of the legislative instrument. And we're very active in the mental health policy that the Mental Health Authority duly launched. And I take the opportunity to congratulate the CEO of the Mental Health Authority, Dr. Professor Akwesi, for his untiring efforts. We have, as Basic Needs, even though we are a non-government development advocacy organization, taken collaboration with government very seriously. And I've worked very, very closely with the Ministry of Health, particularly through the Ghana Health Service. And that is why I was so thrilled that Dr. Kofi Issa is coming to be in this program, for the good reason that he is one of the people who advised us on this program when we first started in 2015, supporting us through getting ethical clearance, advising us as to how to go about this. And I'm glad that, Doc, you are here today to see to the end of this. Thank you so much for coming. So on this note, I could go on and on, but just to say we are very happy that you have made time. I know each of you have competing engagements, and to find time to come to be part of this program, we are very privileged. I would like to say thank you to CBM UK, who have journeyed with us in this program, having taken over from Basic Needs UK, and supported us with advice, with information, with guidance, and has made us reach this far. We also want to acknowledge the funding support of the UK Aid FCDO, Foreign Commonwealth and Development Office, for the funding they have given to this project, and the JC Overseas Aid Commission, or JC Overseas Aid Agency, and the Hadley Trust, who supported us all through these 6 years. We are excited about how far we have come. This learning event is to help us build upon what we have started. And I can assure you that this maternal mental health project is not coming to a close. It's coming to revitalize and probably continue, and would continue in a long time to come. Thank you once again, and you are all welcome.
Thank you very much, Peter, for your word of welcome. So we'll quickly move to invite Kirsty Smith. Kirsty is the CEO of CBM UK. CBM UK is the grant holder, making it possible for us to undertake the maternal mental health program here in Ghana. Kirsty will be joining us remotely from UK on Teams. Kirsty, if you are ready. Kirsty, you can go ahead and speak.
equal basis with their non-disabled peers. This is reflected in our community-based inclusive development approach, which involves working closely with people with disabilities and their families to overcome physical and sociological barriers within communities through a holistic approach to a person and their environment. Partnerships are central to CBM's development approach, as we believe we can achieve greater long-term change by working with and learning from others. We deliver our health, education, livelihood, social inclusion, skills development and empowerment programs by working with local partners, bringing together CBM's expertise with hands-on knowledge of the local context and the environment. We know that 80% of people with mental illness live in low or middle-income countries, where most people have little or no access to treatment or support. This results in many individuals with mental health conditions facing extreme poverty, stigma, discrimination, and abuse. Without more investment in mental health, this will remain a reality for people living with mental illness. The WHO raises the concern that poor maternal mental health can lead to low birth weight, reduced breastfeeding, leading to severe malnutrition, increased episodes of diarrhea, lower compliance with immunization schedules. All of these together hamper a child's growth and delays psychosocial development. Our maternal mental health program's baseline survey highlighted that only 3% of the facilities provided mental health services to pregnant women, breastfeeding mothers, and children. And yet, one of the main findings of the mapping and assessment study were that the health of women and their children had improved through the program's health education, their access to healthcare and to medication. And this is a significant achievement which should be celebrated. Over the course of today, you will hear about the importance of having a standardized screening tool for assessing maternal mental health, and how this program has highlighted a need, and how the screening tool, the PAST, has provided a solution to addressing the gap tailored to the context of Ghana in support of SDG 3. You will be presented with findings and recommendations and have the opportunity to discuss how to continue to move forward in making the systemic change that so many mothers, children, families and communities desperately need in order to thrive. We have more work. We are not yet done. But as this program comes to a close, it leaves many sustainable outcomes. And I'd very much like to thank our donors, FCDO through UK Aid Direct, fund managed by Malan Daniels, and matched by Headley Trust, Jersey Overseas Aid, and CBM UK itself. I would like to thank our incredible partners for their hard work throughout the program, and especially in the face of COVID-19 and all the additional challenges that the necessary restrictions imposed on the program. By training staff, by building capacity, by providing livelihood support, empowering women, delivering training, and raising awareness, our partners have made long-term differences to people's lives, and in some cases, saved lives. One mental health officer in the program stated, "There were a lot of people with suicidal thoughts, but since the program, I can confidently say there are no more people." CBM is proud to have played our role, and we look forward to taking the learning from today forward in our reporting to FCDO. And thank you so much in advance for your contributions to today's discussion. Thank you so much.
Thank you very much, Kirsty. Well, that was a speech we needed. Thanks. I would like to use this opportunity to acknowledge the presence of our implementing partners. So if they are present, CPRI, could you stand up so that we look at you? Thank you very much. So George and Dominic, thanks for representing CPRI. Do we have GKS present? GKS. Thank you very much. So Sheikh and Osman, thanks for representing GKS. That's Group Katimali Society. They are our partners in the northern region. CPRI are our partners in the upper west region. Do we have Mehoso International Foundation present? Mehoso International Foundation is our partner in the Bono region. They are responsible for, or they were responsible for the program in the Brong Ahafo region, which now, as we know, has other regions carved out of it. And basic needs, obviously. So Peter, if you would stand up again for us. Thank you. All right. Okay. So without much ado, I will invite Dr. Kofi Issa to come and give us his remarks on behalf of the Director General, Ghana Health Service. Dr. Kofi Issa.
An administrative correction. I'm actually here on my own behalf. I don't have the Director General's permission to make remarks on his behalf. I'll get a very strong query. But being the director in charge of family health, which actually includes maternal health, permit me to make a few remarks, which would also be the position of the Ghana Health Service to a large extent. Normally when we talk of maternal health, everybody thinks of the physical health of the mother. But as time goes on, we seem to realize, growing up in our own communities, that there were issues which arose which we didn't understand, befell our sisters, our mothers, our aunties. As society has grown a bit much more complex, the issue of mental health for the mother, for the household, and for the community has grown more complex. And so normally we go in and at annual reviews, the whole indicators are how many mothers had PPH and how many mothers had hypertension and how many mothers have this. But in our society, it's become very difficult. When they say, how many mothers had depression, then everybody shies away from that situation. And that is something we have realized as a gap, as a division. And definitely, if we have to provide care to our mothers, it has to be holistic and follow the original definition of health, that it would not mean things which are just physical but mental. Let me say it's always easier said than done. And government, and for that matter, its agencies are not always the best people who can work in the communities. My friend Dr. from Mihoso will know better as we normally interact. And I simply say, so look, you come for something much more technical, and then you normally have the community entry skills to be able to interact with our communities. So the maternal mental health is a huge one. I don't want to go into the health economics of it, but it's something in which we would have together to put on the front burner. COVID just went, or is still on. We don't know what is coming next. What was it which even prevented mothers from accessing care as far as physical health is concerned. And definitely what was the whole situation of women agonizing together with their children, together with their families within the communities. So in participating in this program, it is something in which we mandated for maternal health in Israel. We would also have to learn from partners that together we can be able to make sure that we put the health of the mother, and specifically the maternal health of the mother, as a priority. And that, yes, eventually if we are able to simply tackle this and tackle it head on, it should be able to contribute to improve the health status, not only of the mother, but the children and the family as a whole. So once again, let me thank Basic Needs for the opportunity. I think we have been circulating around each other, I think for the past 15, 20 years. From Yendi to Sunyani to every region I go, I think they follow me or I follow them. And now in Accra, I have followed them to Accra. Thank you very much, and God bless you all.
Thank you very much, Dr. Kofisa. I must say that just within this period, I've met Dr. Kofisa in 2 regions. First, in the Pono region, when we went for the monitoring visit, he didn't tell us he was moving to Accra. Only for us to come to Accra and meet him here again during the evaluation period, that he was already here in Accra. And we are always grateful for your reflections on our work and being a critical friend. I will want to invite Dr. Levina to come and give us some brief remarks on behalf of the WHO. Dr. Levina, let's welcome her with a clap.
Good morning, everyone. So I stand here on behalf of Dr. Francis Kasolo, who is the WHO country representative for Ghana, to make these remarks. The Executive Director, Basic Needs Ghana, all development partners present, friends from the media, and all distinguished guests. We wish to congratulate Basic Needs and partners for undertaking such an important project aimed at improving maternal and child health outcomes in all girls and women in Ghana. Pregnancy and the postpartum period, we know, increases the risk of mental health conditions in as much as 20 to 30% of women in developing countries, as found by WHO in 2008. Maternal mental health conditions are worsened by poverty, intimate partner violence, and others, such as unintended pregnancy, some of which was alluded to by Kirsten. These conditions include anxiety, depression, bipolar, substance-related disorders. Depression in the postpartum period may be complicated also by unfortunate ending of the life of the newborn in very severe cases. In addition, it may affect the growth and development of the newborn adversely, as the mother may not be able to take care of herself as well as the newborn. In Ghana, the rate of depression in pregnant and postpartum women in 3 health facilities was estimated to be about 27%, research done by Sofoga et al. In 2020. It is therefore important to look out for these conditions through screening and putting in an intervention to address them. The WHO deems addressing maternal mental health an important component of comprehensive health care, which directly improves the Sustainable Development Goal 3, which ensures healthy lives and well-being for all ages. This goal specifically is concerned with reduction in maternal mortality, newborn death, and reduction in premature mortality from non-communicable diseases through prevention and treatment and promotion of mental health and well-being. I hope this conference will lead to the implementation of the findings on improving maternal mental health for all women in Ghana. In addition, the lessons learned from the outcome of the pilot of the maternal mental health screening tool project will be shared as best practice with the world, which will lead to the closing the maternal mental health treatment gap and ensuring healthy lives and promoting well-being for all ages. On this note, the WHO wishes Basic Needs Ghana and its team, as well as the team of collaborators, a successful conference deliberation. Thank you.
Thank you very much, Dr. Levina. Please, let's give her a round of applause again. So we would like to acknowledge Dr. Emmanuel Asampong from the School of Public Health, University of Ghana. Doctor is seated at the back there. Doc, thanks. We would like to acknowledge our invited guests from Johnson & Johnson, if you are here. Johnson & Johnson, thank you very much. It's not every day you see 3 people representing Johnson & Johnson at a program. We thank you very much for coming. We would also want to acknowledge the presence of the media houses who are here with us. I see Rebecca and some other media houses. We thank you very much. So I would like to invite Dr. Atta. Dr. Atta is from the Mental Health Authority to give us brief remarks before we go into the presentation.
Thank you. Good morning, ladies and gentlemen. I am reading this on behalf of Professor Akwesi Osei, the Chief Executive of the Mental Health Authority. Ladies and gentlemen, foremost, let me render my sincere apologies for not being present and unable to participate in this timely conference. An equally important matter had taken me far off before this day. Ladies and gentlemen, we are gathered here because of the Ghana Maternal Mental Health Program implemented by Basic Needs and collaborators. To give a brief context, globally, maternal mental health is a significant program because in the global north, the prevalence rate is estimated to range from 18% to 38%. In the global south, the reported prevalence rate ranges from 15% to 57%. Conservative estimates in Ghana suggest that maternal mental health, these rates of prenatal depression is also estimated at between 10 and 38%, whereas prenatal anxiety is estimated at 33% and postnatal depression between 4 and 9%. The reason for these high figures are that our women are vulnerable to risks such as low socioeconomic status, poverty, unemployment, low social support, domestic abuse and violence, among others. Ladies and gentlemen, as you are aware, poor maternal mental health has very dire consequences for the mother as well as the infant. And indeed, in certain cases, it might extend to other members of the family. For example, with regards to the mother, untreated prenatal and postnatal maternal depression and anxiety is associated with significant functional impairment, psychological distress, and parenting difficulty. Maternal mental health problems are known to be associated to peripartum and postpartum complications with detrimental consequences for the child, such as preterm birth, low birth weight, poor growth outcomes in the child, among others. All these effects have been strongly linked to mother and child morbidity and mortality. Accordingly, considering the impact of maternal mental health on other members of the family, we can imagine the enormity of the problem at hand. It is crystal clear why maternal mental health should be considered as an important issue, and therefore not out of place to say that we need robust interventions to address maternal mental health challenges. That being said, I must tell you that I was very excited when I got to know about this program, because this program sought to address a fundamental issue but had other significant ramifications that cannot be ignored. In fact, it is worth noting that the significance of this particular program is embedded in improving the physical, psychological, and financial needs of women, including poor, vulnerable girls, the new infants, and the children. Ladies and gentlemen, please allow me to take this opportunity to express my profound appreciation to UK Aid, Jersey Overseas Aid, and Headley Trust for providing the funds for this program. It is a demonstration of their understanding of the problem at hand and their commitment to support and address a concerning problem. On my own behalf, the Mental Health Authority, the beneficiaries of this program, the Mental Health Fraternity, and the people of Ghana, we are indeed grateful and we say thank you. In the same vein, ladies and gentlemen, let me also congratulate Basic Needs Ghana, Gum Katimali Society, Mehoso International, Center for People's Empowerment and Rights Initiative, and CBM in particular for implementing this intervention, and others who in diverse ways supported to make the program implementation successful. Today, we are gathered here to listen and deliberate on the evidence that has been generated from this intervention program. I cannot overemphasize the importance of using evidence in the delivery of mental health services and practices. Therefore, I want to acknowledge the rigor with which this intervention was designed and implemented, particularly using validated tools and evidence-based approaches in collecting the data. This would provide the evidence needed for service and practice improvement. Similarly, lessons learned from such an intervention can be applied and further improve other programs. Therefore, ladies and gentlemen, permit me to implore on other implementing agencies in mental health interventions to adopt rigorous methods when implementing programs in order to present us with quality data. Talking about quality and aspiring to provide quality mental health care to our clients, ladies and gentlemen, I seek your consent to use this platform to mention the Quality Rights Ghana initiative, sponsored by WHO and supervised by the Mental Health Authority. As a matter of fact, Basic Needs is an implementing partner in this initiative. For the benefit of those hearing about it for the first time, this is a capacity building, free, available online training program. It provides trainees with the knowledge and attitude to understand and promote human rights and recovery of persons living with mental health conditions. I encourage all of you to have a go at this training if you've not done it, and urge others to participate as well. If you want to know how, just go to Google and type in Quality Rights Ghana, one word, and follow the prompts to the e-training platform, and you are good to go. Finally, ladies and gentlemen, I will miss the passion of this program. I would have loved to hear everything firsthand. Meet both old and new stakeholders and partners to share ideas. However, I have no doubt in my mind this conference would be successful in churning out the evidence we so much desire to improve maternal mental health in particular and mental health care in general in this country. Accept my best wishes in good faith and have a successful conference. Thank you.
We can do better, please. Dr. Atta, thank you very much. And our warmest regards to the CEO of the Mental Health Authority. Allow me acknowledge the presence of Dr. Amabwedu. Dr. Amabwedu is the focal person for mental health at the Ghana Health Service. If, Doctor, you are here. Thank you very much. I would also want to acknowledge the presence or representatives of Shraj. If Shraj, your representative is here, thank you. Human Rights Advocacy Center, thank you. And Dr. Adjua from NHIA, National Health Insurance. And all service users and caregivers who are present, you are very much welcome. So, Dr. Wack is the consultant who led the evaluation, end of project program evaluation, and he has a presentation to give us. I believe this is the crux of the reason we are here. And so I would want to crave your indulgence and welcome Dr. Wack to give us his presentation. Doc, over to you.
We should put off the lights. The camera people need. Part of the one by you. No, up. Okay, good. Great. Okay, thank you very much. Let me start by giving thanks to Basic Needs and the partners for making it possible for us to share the results of the evaluation. Basic Needs started this work in 2015 on enhancing maternal mental health and livelihood of vulnerable pregnant women and mothers and their children to realize maternal and child health in Ghana. Prior to implementing the program, they did a baseline, and then they followed up with a midterm evaluation. And then we also did an assessment of the referral as well as a pass-through assessment. And now we are thankful. After the evaluation, we are here to share with you. I'm doing this on behalf of my colleague and myself, Dr. Joyce Dare. So my presentation outline would be as you can see. I'll be talking for close to 1 hour. So please brace yourself for sitting for long. Right, so by way of introduction, other speakers have mentioned this already, to the fact that mental health is a well-known public health problem, and it has caught the attention of government and non-governmental organizations. The critical situation of mental health is also that which affects women. And as we all know, women are vulnerable, particularly in rural areas where poverty and economic deprivation is pervasive. Even though in Ghana, policies are bound to deal with mental health issues, we haven't been able to achieve the desired results. This has technically been as a result of system challenges, among others. Others including people lack of understanding of issues pertaining to mental health, cultural beliefs, sometimes even religious beliefs. Somebody goes through mental health problems and then several attributions, and then it's ignored rather than seeking solutions to these problems. Beliefs and practices has put those people in danger. To scale this over this problem, there is a need for other people to come in, particularly non-governmental organizations. Government alone cannot do this. So we need partnership to be able to get over this problem. Even if we cannot eradicate it, at least we minimize it as we go along. So as a result of this, we actually appreciate Basic Needs involvement in this direction. So what did they do? The Maternal Mental Health Program. Like I said, it was implemented in 2015. And the main objective of the program was to contribute to the improvement of maternal and child health outcomes for poor, vulnerable girls and women. That also would include their children. The main outcome was for poor and vulnerable women to have improved maternal health and livelihood. Basic Needs did this through some partners. They have been acknowledged already, but I also have to mention and acknowledge them because we work closely with them at the time we were in the field collecting data. GKS in the northern region, Mihoso in the Brong-Ahafo, and like Fred said, Brong-Ahafo has now been divided into several regions, 3 now, but that's at the time of the implementation of this program. Mihoso was operating in the whole of the Brong-Ahafo region, and I presume they still do that. And then CPRI in the Upper West region. So Basic Needs under this program undertook some activities, and I would want to highlight a few of them. One of the key things they did was to train health staff and then community-based volunteers to identify women with mental health illnesses. Basic Need also, under this program, introduced a screening tool, that's a PASS tool, to assess women with symptoms of mental health illnesses. They also trained women in livelihood activities. They provided support, both financial and material, to women to engage in income-generating activities to support themselves and their families. The critical aspect was also the education of women in safe care, and then to generally improve upon their healthcare seeking behaviors, particularly for care for pregnancy, breastfeeding, and then so many others. Now, we were tasked to do an end-line evaluation. So a call for proposal was put out there, and then we applied, and then we were selected to undertake this evaluation. Within the frame of the terms of reference, the objectives for the evaluation are as listed. Quickly, I will go through them. We were supposed to assess the performance and achievement of the project objectives and the factors contributing to the achievement of these objectives. And I've outlined the objectives in the previous slides. We were also to determine the extent to which the project design was relevant and appropriate in meeting the needs of beneficiaries. Then we're also to examine current sustainability measures of the approach and validity to the degree to which the project has set a foundation for the promotion and systematic policy consideration of maternal mental health issues in Ghana. And then lastly, we're to document lessons learned from project planning and design, implementation, monitoring, and learning for onward sharing and guidance of future projects. So we're supposed to work around these 4 thematic areas of the terms of reference. So what did we do? We used a mixed method approach, both quantitative and qualitative. That was to allow us to get an in-depth understanding of what the situation is pertaining to participant experiences. So in all, 3 districts were selected across the 5 regions of operations of Basic Needs. Upper East, where we worked in Talense, Bongo, and Bolga East districts. Greater Accra region, Ayawaso North, Legma, and Esiedu Keteke. And then in Upper West, we work in Adoli, Kelio, and Njirapa districts. Northern region, we work in Anumba North and Anumba South. And in Brong-Ahafo, we work in Tana North and in Kransa South. So this is the map of the areas where we conducted this survey. In Greater Accra, because the areas are very small, the colors are not showing. So we use a systematic sampling method in selecting 264 women attending antenatal clinic and postnatal clinic. So for the antenatal, we selected 156, and then for postnatal, we selected 108. And then we use a purposive sampling method to recruit all our stakeholders to have an interview with them pertaining to maternal mental health in the various districts. At the various district and health directorates, the directors, public health nurses, and then the mental health officers were interviewed to get their perspectives with respect to mental health issues in their area of jurisdiction. At the national level, we had the opportunity to interview the Director General of Ghana Health Service and then the CEO of Mental Health Authority. We had a lovely chat with these two important people. Then institutions that were purposely selected for interview included District Assembly and then the social welfare, since they also have something to do with respect to people with disability. That includes people with mental health illnesses. So we collected data from stakeholders using a questionnaire guide through community key informant interviews, as well as in-depth interviews, and then focus group discussions. Health staff at various categories, like I mentioned, heads of health institutions, as well as pregnant women, mothers of children who were aged less than 2 years, were all interviewed using an in-depth interview and focus group method. Semi-structured questionnaires were used to collect data from partners and institutional leaders. And then data was entered, cleaned, and exported to Stata software version 16 for analysis. For the quantitative data, means and standard deviations were calculated for continuous variables. Frequencies and proportions were also calculated for categorical variables. For the qualitative, we recorded, transcribed, and analyzed using thematic analysis method. So now let's come to what we found. We would, I'm going to present the results according to the various objectives that were set for us. So for the first objective, as I indicated, we were to look at the contribution of the program to the improvement of the health and livelihood of the beneficiary women and their children. So under this, we are going to use several types of the data that we collected to be able to look at this objective. So we start with the women attending ANC and PNC. And then I'll show you some tables giving us some responses, and then we see proportions of some of the responses of interest, and then we can make a judgment. So here we just basically look at the characteristics of the women we interviewed. So for the antenatal women, that's women who were pregnant and were interviewed at the antenatal clinic point. Their mean age was 27.5. The range of ages 15 to 42. For marital status, 78, close to 79% of them were married, and then the rest were not married. And the rest who were not married included people who are divorced, separated, widowed. So we just put all of them as not married. I mean, the numbers were quite, some of them were quite small, so we couldn't separate them. For education, 15% were uneducated, didn't have formal education. 14% had at least primary education, and then 70.7, close to 71%, had secondary plus. And the secondary plus here include those at the GHS level and above. Now for those postnatal women, those women with children less than 2 years, at postnatal clinics we interviewed, the mean age was 28.2. The range is the same as the others, 15 to 42. For marital status for this group, 81% were married and 19% were not married. For education, 20% didn't have any formal education. About 19% had primary, and then 61% had secondary plus education. Now, take care of myself. Now, for the question as to whether their health status and those of their children have improved, the quotes below point to a positive outcome of their health status. So one of them said, "Now I have hope and do not worry about anything, and it gives me peace of mind." One also mentioned, "I lost my husband after delivery, and economically it was difficult. Joining the self-help group, I am empowered financially to be able to put my child through school." Then the other one also said, "I have a problem with anger. So I learned how to control my anger. Also, I am supported financially to support myself." Yeah, this is one of the pictures my colleague Dr. Joyce was having a discussion with the women in one of the places. Now, from what we have seen, we want to draw some conclusions on Objective 1. So we would say that evidence from the results presented so far suggests that the maternal mental health program has been beneficial to the women and their children. The support and education they receive from the program through the self-help group has generally contributed to the improvement of the health and economic well-being of the women. In conclusion, the program has achieved this objective of improving the health and the economic well-being of the women and their children. The contributory factors responsible for the achievement of this objective include: 1, screening processes, training of health staff, health education to the women, livelihood support, and then the self-help group meetings that these women have been organizing with support from the partners in the various districts. Now we would look at Objective 2. The Objective 2 is talking about evaluation to determine the extent to which the project design was relevant and appropriate in meeting the needs of the beneficiaries and achieving the set objective, taking into account the various changes to project logic. Now, to answer this objective, we look at the target group and see whether that was appropriate. So the target group of the program was relevant in achieving the program objectives. So this is shown in the results following. So we go back to membership of the self-help group. That the women we selected randomly and interviewed, like we said, close to a third of them belong to a self-help group. In terms of benefit, as high as 93% benefited from the program, being part of the self-help group. Awareness and training of community-based volunteers. These volunteers were trained to offer services and assist women with mental health illnesses. So in selecting them to do this was very appropriate. And we interviewed these volunteers to find out their perspective. So 97% of them mentioned that, yes, in their various communities, there are problems with maternal mental health. And we asked them whether they are aware of the program, the maternal mental health program. And as high as 98% mentioned that really they are aware and they've been working in partnership with the program. And we asked whether they received training. About 87% mentioned yes, they were giving some training. And we asked whether they think the program has been beneficial to the target group of the population. And about 97% mentioned that yes, the program has benefited the target group in various ways. Now, training of healthcare workers. We also realized that it was appropriate actually getting to healthcare workers to train them, because they invariably will be looking at these women, trying to screen and identify, refer, and treat. So they also needed training, and the selection of these healthcare workers, in providing them this training, we found was very relevant to the program. So we have a quote here from one of the directors, district health directors, and the person said, oh no, it's a female. She said, it has helped our midwives to appreciate mental health. Some of them waited till a woman would give birth and develop psychosis. They were not interested, but the training has helped them to appreciate it. They have seen it to be part of their activities and not only for mental health nurses. So previously, the issue of mental health was relegated to only the MHOs, the mental health officers. But with this program, training being given to the midwives, they all now have come to the realization that this problem of mental health belongs to all of them, but not just the mental health officers. So training of health workers to be part of this was actually relevant. Now, health education. The strategy of educating women on safe care has helped achieve program objectives, and then we have listed a few of them from the data. So, number of antenatal visits, which is very important in the improvement of child health. In terms of number of visits, as high as 85% of the women reported having visited antenatal 4+. In terms of breastfeeding, with respect to exclusive breastfeeding, 63% did exclusive breastfeeding between 5 or more times. 5 or more times. You have 19% who didn't do breastfeeding at all. And then 18% did less than 5 months. And then we think that whereas 62% have actually done exclusive breastfeeding between 5 or more months, well, it's quite good, even though we would have expected that the proportion would have been higher. But remember, most of these people are in the rural areas where for some reason they are not able to do exclusive breastfeeding for a very long time. So we have a quote here from them, and then one of them says, they taught us when you are pregnant how you can take care of yourself and how to breastfeed our babies and take good care of them. This is a woman from the Nkransa South District. Now, findings from the in-depth interviews with implementing partners also supports this point, where it was said that safe care training led to babies completing all required immunization. And because there was improved recovery of mothers, they were able to bond with their babies. Now, we also interviewed a group of people in terms of formation of or being part of the self-help group. And then as I showed earlier on, 93.4% of the women who belong to any of the self-help group benefited from the program. Improvement in mental health, 97% responded positive, that yes, their health status has improved. And in terms of economic status, 98% responded yes, their socioeconomic status has improved. So it was appropriate in selecting this group of people for this program. Now, this objective, from what we found, was also evident by quotes from the focus group discussions. First of all, we look at the reasons for joining the group. My husband died and left me with 5 children, so I was always thinking. So I was referred to join the group, and since I joined, I have no problem. They gave me money to take care of my family. I joined this group so that I could meet other sick people like me, so that we can support and encourage each other to have peace of mind and feel belonged. In terms of benefit, we have this quote from a member in the Jirapa district. Now I have hope and do not worry about anything, and it gives me peace of mind, as I showed this quote earlier on to buttress the point of meeting the first objective. Now, benefit in respect of economic status. There is a quote here. I have learned soap making, which I sell to get money to pay my children's school fees and renew my health insurance. I'm able to catch one of the fowls we mentioned this, but this is also to buttress the point that, yes, the selection of these women was appropriate with respect to the program plan. So now we look at Objective 3. For Objective 3, we were supposed to examine current sustainability measures of the approach and the validity of the degree to which the project has set a foundation for the promotion and systematic policy consideration of maternal mental health issues in Ghana. So here we talk to key stakeholders, and other partners. And then they suggested various ways for which we could sustain the gains made by this program. Now, for the self-help groups, during the discussions, we told them and we asked them what can they do to keep on the good work of the program now that the program has come to an end. So some of them made some suggestions which is quoted here for you. So they said, what we can do to support ourselves is the reason we are doing SUSU, that's contributing money, so that if no support will come again, we can use it to support each other to continue our work. Now, from the perspective of the stakeholders, for Ghana Health Service team, the interview that we had with them, what they mentioned was that Ghana Health Service can absorb the program and integrate it into routine care, especially adopting the screening tool for assessment to ensure the early identification of maternal mental health issues and treatment. So a quote here from one of the mental health officers, that Ghana Health Service should integrate the screening into routine care to be sustained by making it a policy. Now, we also got this view from one of the health workers, that training of healthcare workers, especially new ones, should continue so they can continue to screen for maternal mental health issues. Some of the health workers receive training, but because of attrition, transfers, going to school, and then new ones come over who haven't received training, the suggestion was that, well, the training should be ongoing, periodically training new ones who will come to continue this good work. So a quote here, I think the district should integrate maternal mental health in their training plan, so health workers will continue to be informed and identify cases. Then we also were told, as a suggestion, that monitoring of the beneficiaries to ensure livelihood activities are sustained. So in order that the women keep up the momentum of what they have been doing, because in the past with this program, they were monitored, supervised, educated, redirected, and all that. But with the end of the program, what will happen? So the suggestion was that monitoring should continue. So a quote here says that as part of closure of the program, a session should be held with beneficiaries to inform them that monitoring of livelihood activities will continue, so they would be serious. We will continue to monitor the women to ensure their businesses do not collapse. This is coming from a public health nurse in one of the institutions as ways of trying to keep up and to sustain the gains that have been achieved. Yeah, so this is a picture showing interaction with one of the district directors of health. Now, we also had interaction with the stakeholders at the social welfare department. So what we got from them in terms of ways of sustaining the program is that beneficiaries of the program could benefit from the disability fund and LEAP. However, the department must be furnished with a list of beneficiaries so they can be contacted or linking them to establish businesses. So this is a quote from one of the social welfare workers, that we can contribute to the sustainability of this project by getting data from the mental health officer. Once they are part of the 3% common fund, we can always give them assistance with the fund. But we want the data because the fund is being competed for by a lot of people. Now, another quote here from another social welfare officer we can identify people, that's the beneficiaries, and match them to established businesses so that they can make some income and win themselves with time. For example, if the person sews a dress, she gives 20% of the money received to the owner of the business and keeps 80%. During the course of deliberations with respect to this aspect, we also talked to the district assemblies. Mostly we talked to the coordinating directors with respect to how the 3% disability fund is disbursed. In the past, it used to be 2%. It was increased to 3%. Then what we have seen, even without interviewing them, was that people with mental health always don't come up. They are always shy because of stigmatization. And sometimes they don't even see themselves as people with disability. So when they are dispersing the fund through applications, these people don't have the opportunity to also apply. In any case, when they apply, those who do the assessment and to select beneficiaries always don't think that these people need help. I mean, you see a mentally ill person. I mean, sometimes people would think that they are those who are walking the streets. As we went through the district and having focus group discussion, it will be very difficult when you are sitting with them to note that this person is having a mental health problem. No. But the disability fund always target more with respect to the physically challenged people. Because for the mentally ill, they don't see it. And so they are always relegated. And then these mentally ill people also are not educated to know that they are even qualified to also apply for that. So education has to go on for them to also understand that they qualify and so they can apply. This will require education to these people at the various levels. So the social welfare officers had actually brought this up, that we need to get their officers to get to identify these women and then provide some sort of support. Now for the last objective, which is for us to document lessons from project planning and redesign, implementation, monitoring and learning for onward sharing and guidance of future project management. So the important aspect of the program implementation has been the partnership with the various institutions, CPRI, MIHOSO, GKS, and all the others. So in terms of the planning, involving these people has been very key because they are on the ground, seeing to all the program implementations and doing all the work with respect to meeting these women, helping them to get their medications, referring them, and doing all this work on the ground. So specifically here, the mobilization of the women by these partners for various program activities has been very beneficial. So that is a good lesson that we have learned from this. Also working with the Ghana Health Service system, because when you talk about mental health, it's a health problem, and so it's under the purview of Ghana Health Service. So working with Ghana Health Service is also an important lesson that we need to learn, and it's a very good approach. In particular, the critical role played by the health workers, midwives, community health officers, CHOs, has contributed to the success of the program. This is also good for issues pertaining to sustainability, because they are those who will still be on the ground to still work with these women. So the knowledge they have acquired through the trainings, the motivation, the understanding of issues pertaining to mental health is still with them, and they can continue to utilize that knowledge to still work to improve upon the lots of these vulnerable women. So having dealt with all these objectives, we are now looking at the key findings of the study. In fact, there is a lot we have, but given this time frame, we just pick the key ones, and then during the main, writing the main report, we embedded all the issues that came up. So the key finding is that the maternal mental health program has been beneficial as it has created awareness on maternal mental health among healthcare workers and community members. As we went along, you see excitement in this group of people. They would tell you that in the past, people with mental health illnesses. Some of them are locked in a room. Some of them are chained in prayer camps. Some of them are locked in healers' homes. They don't come out. They treat them. And some of them their illnesses are attributed to curses and some other happenings. And so people don't pay attention to them. But with the mental health program, they also feel that, yes, they are also recognized. I mean, these are people, like I said, you will never notice until you are told, or until there's one attack or the other, then you realize that this person has this problem. Otherwise, you see them as all of us sitting here. So they actually appreciate the fact that the program has come to change all these dynamics, people's mentality about people with mental health. So that is one of the key findings that we are coming up with. Then we also say that the program led to the screening for mental health illnesses by health workers among women attending antenatal and postnatal. This part of the program has actually resulted in the early detection of women with mental health illness and appropriate treatment given. We also found that the creation of the self-help group has created the awareness and avenue for women with mental health illness to meet, motivate, and support each other. This has made the women to know that they are not alone in their challenges. They feel that they belong and are confident in themselves. During the discussions, it came up, and it's probably maybe a common knowledge that usually when we have a problem, we think that we are the only one in it. You have 20 cedis in your pocket and you think you are poor. Somebody has 10 pesos and it's appreciative. It is only when you get to know that, oh, I am better than this person, or I have similar problem with this person, and then you appreciate the fact that you are not alone in this. And then you keep thinking, why me, why me, why me? And then it bogs you down and rather depreciate your health. But they are saying that with the self-help group, mobilizing them and coming to give them talks, they realize that they are not alone in this. And it gives them a lot of relief, coupled with the education, motivation, and then the support that they get. It keeps them alive and gives them hope. There is also the concept of saving, like the other person mentioned with regards to the susu, that it has led to all groups initiating contribution of monies which they use to support themselves. In one of the meetings, we were told that periodically they mobilize to visit each other. Particularly if here one of their colleagues is not well, they have a funeral, somebody has given birth, the group mobilizes money to support that individual. So at least they also feel that, yes, they belong to each other. In fact, in one of the places, in some of the places, we were told that people who are not even ill want to join their group because of the benefits that they are getting, the cooperation, the support from each other, that people who are not even ill wants to join them. Then the other key finding is that the livelihood training and support has empowered the women as they are now engaged in income-generating activities from which they get some income to support their families. And it will interest you to know that they do all manner of businesses. Because some receive financial support, they buy items to start some tabletop provision sales and other things. Some were given freezers, fridges to sell pure water and other drinks. Some were provided with animals to rear and all type of support given them. So they rely on this to get income to support themselves. Importantly, they mentioned the education offered to them on safe care that has enabled them to better take care of their children and then they themselves. They have learned the importance of child welfare activities, including exclusive breastfeeding and vaccinations, which has led to general improvement of the health of these women and their babies. Hitherto, because of their conditions, they will not even come out. The moment they have the baby, they are stigmatized, they are not motivated, they are not encouraged, so they are always indoors, and so the babies are also affected. But with this program, it has taught them lessons, education in terms of how they are also useful and their children also being useful. So apart from their health, they should also think of the health of their children who are not ill like them, but if they are not careful, their illness will also result in the child also falling ill if they don't go for the postnatal care. Then there have been improvement in collaboration between midwives, mental health officers, and other healthcare workers in addressing mental health issues. In the past, these health workers were working in isolation separately. The mental health officers are somewhere, the disease control people are somewhere, public health nurses somewhere, health information. But with this program, it has resulted in cooperation and working together between and amongst these groups of health workers. In all this, there had been challenges that came up. And then we also noticed some of these challenges that we want to bring up. And we are saying that stakeholders' engagement at the national level and the collaboration between partners and stakeholders at the district level has been suboptimal in some districts. Now we are talking about sustainability, the program coming to an end, and we want to sustain it. And for sustainability, various groups and institutions have to continue. So the Ghana Health Service have to continue with some aspect of the work. And at the district level, the staff there take instructions from the regional level. The regional level take guidance from the national level. So we thought that the engagement should be continuous and regular from the top level so that sustainability and continuity is not limited to the district level, but rather scaling down from the national level. The Director General brought this up when we interacted with him. He's aware of the program, but he's not been briefed as we went along. So he says that in the future, we should periodically meet, not just at the lower level, but at the top level, so that when it comes to sustainability, implementation, or continuity, at least everybody will be aware. Then there was also intermittent suspension of the program at various points in time. That also affected the program. But it was all for the good of the program. But in view of the good things that we were anticipating, those intermittent breaks also affected the program. We noticed that maternal mental health is not a key priority in Ghana Health Service, as this is evident by the lack of interest shown by some district directors and health workers in the program. I must say that as we went through the various DHMTs, District Health Directorates, the mental health officers have complained. They don't have their own offices. They are always perching, as we say. So at one point, they are sitting with disease control people in their office. At one point, they are moved somewhere. In one of the places, the mental health officer was sitting with a midwife in her office. So you realize that, yes, the mental health is not, or has not been a key priority in Ghana Health Service. And so we think that it has to be prioritized as the other sectors. A typical example is these people complaining of not being given offices. So sometimes in the places, these people with mental illnesses come for care. And the mental health officers need to interview and take them through certain discussions. And it requires privacy. So if they don't have their own offices and they have to sit in the open where other people are sitting to discuss some of these sensitive issues, that is a bit problematic. Then the other problem that came up was their medications. Periodic shortages and unavailability of the mental health medications has been a few concerns, because usually when they default for some time, they get relapses. And so we notice that that is a challenge that we need to address. There is also inadequate monitoring of beneficiaries in some districts due to lack of means of transport for that purpose. So the volunteers who have been supporting these women in various ways have complained that because they don't have means of transport, even if they have, how to get them to move becomes a problem. And so sometimes when a case is reported, how to get to see that case and to act becomes a problem. So, and then just the general monitoring of beneficiaries also with respect to the self-help group, those who have been giving support, to see what they have done and to advise them was also another challenge that came up. So we have put up some few recommendations. So we are saying that given the important contribution the program has made to the health of the women, it is recommended that in future adequate and periodic briefing meetings should be organized to improve collaboration among stakeholders at the local, district, regional, and national levels. This will, for instance, easily lead to collective advocacy for policy to integrate maternal mental health screening into routine care by Ghana Health Service. So at one point, during our discussion with the Director General of Ghana Health Service, we were thinking the PASS tool that was used, which has been found to be very good, at some point, can we integrate it into the training of students of mental health so that it becomes part of the routine mental health education, so that automatically is being used. But the challenge also here is that these women we are talking about are women who attend antenatal and postnatal, who are taken care of by midwives and other nurses. So we have to find a way of integrating this into the system where the mental health officers would be part of the postnatal and antenatal clinics so that they can also be doing it. Because it came up that at the time of the implementation of this tool, the midwives and the nurses at the ANC and the PNC were overburdened, because apart from attending to these women and be able to attend to a number of them in a day, they had to go through this form, checklist, and then be taken, and then that takes a lot of their time. So they brought that up, that there's a need to find a way of integrating the mental health office into this so that to ease their work. And I'm sure the mental health officers will also appreciate it. And then the good thing will be that women with mental health illness will be identified as early as possible and then appropriate treatment given them. There is also a recommendation that the financial and material support given to these vulnerable women has contributed greatly to improve upon their health and economic status. But then it came out that not all of them benefited from this support. Yes, I mean, we know we don't have it all. Sometimes financial challenges, limited resources will not allow us to do all the things that we want. And so we are saying that in future programs, partners and coordinators should ensure all members should be given some sort of support. In situations where that is not possible, then engagement with these women should go on and then clearly stated to them periodically. Otherwise, they feel that why have they been left out? The problem we noticed was that, yes, at some point, the support was given, and then others joined later, by which time support wasn't coming again. And then they think that support should be coming at all times that somebody joins the group. But support comes periodically, and at the time that somebody joins, the support is not coming, and they think that they have been left out in a way. So we are recommending that when that happens, periodic engagement with these women should go on and then explain to them. The Social Welfare Department provides support to people with disability. So it is recommended that there should be stakeholder consultation with the department for livelihood support for women with maternal mental health challenges. This will ensure that possible duplication of support to some individual is avoided. So, and this applies to the district assembly. So the district assembly is also give support to people with disability. And with funds from the Assembly Common Fund, which I mentioned is 3%. it was revealed that that support mostly go to people with physical disability, to the neglect of people with a mental disability or mental illness. So we are recommended that in future, the program coordinator should liaise with the district assembly and the assembly members of the various electoral areas to educate and encourage people with poor mental health to also apply for the Disability Common Fund. Like I mentioned, these people sometimes don't even know that they are part of people with disability. So it doesn't even come to their mind that they should also apply for this. An important component of the program is the use of the screening tool, the PASS tool, for the assessment and identification of women with mental illnesses. So we are recommending that the tool be adapted for use in health facilities, because some of the working districts, didn't benefit from this screening, and some used it. And so the district that didn't use the screening tool, because they have friends in the screening district, they got information that the screening tool is being used and it is quite good. So other districts are also complaining and then asking for the tool to be brought to their areas for them to also use. So we are recommending that the adoption of the tool should come up so that other, in fact, health facilities could use it, so that we can identify these women with mental health quite early and the appropriate treatment is given timely. And then the last recommendation, in future programs, stakeholders' engagement should be strengthened at all levels so that continuity and sustainability become easy when the program period elapses. Yes, I think I'll pause here, and then if there are questions, I can take them. Thank you.
Thank you very much, Dr. Wak. Let's give him a round of applause again. I think this has been a marathon, and our snack is due. So we will pause, go for snack break, and then when we come back, we will continue with our program. But before we go for the snack break, I would want to inform you of the exhibition table at the back there. They are made up of, or we are exhibiting items that have been produced by some of the self-help group members who are here. So self-help group members, who, if you are here, let me see you. So feel free to interact with them, talk with them, find out what their experiences have been, and then we'll come back in 15 minutes' time. When we come back, we will have a very short message from the representative from the Ministry of Gender, Children and Social Protection. I apologize for the delay in acknowledging you, and please enjoy your snack. Thanks. We come back in 15 minutes. And I've been asked where the washroom is, so if you just go out and then orient yourself towards the right and head straight, you'll see the washrooms there. Thank you.
You came yesterday? Yeah. Oh, okay. Where is Alaji? Alaji was. Oh, okay. I saw him there.
Look, that was a marathon. Yes. How are you, Asma? That's a good news. Ghana Somubi. I didn't acknowledge you. Sorry. Hey, where are my people? I asked them to be writing the names of. Oh. No, Peter, yeah. 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 Oh, let me. So you see, learning managers are interested in lessons. You know, he did it and so you can scroll here and find it. Sorry.
Because they are more careful.
So thank you for your presentation.
Oh, all right. Thank you too.
I wanted to capture some of the lessons learned. You
No,
mentioned the lessons learned.
oh, but you can make it available to you.
I
Otherwise,
wanted
the
to
comprehensive
ask,
report that will have more of, because there are some of them that you didn't.
I wanted to ask a
There are
question